San Antonio starts right now.
Starting lineup for your San Antonio Spurs.
I was born and raised in San Antonio, Texas. My parents met and married on the east side of the city, but later, when my sisters and I came along, my parents were faced with some tough decisions. Much of their life, their previous church family, their friends that were like blood relatives were all situated on the southeast and east side of the city. But even back then, my parents knew that when it came to our schooling, there seemed to be a better chance of more opportunity if they moved across town. So they did. They worked hard and insisted that their girls would grow up as North Side Independent School District kids. But what led my parents to think this way? Was it just in my parents' imagination that there might be some opportunity differences and variations in the quality of education we'd receive simply based on the zip code we lived in? Of course not. In fact, it's not just opportunity gaps in schooling that exist from one neighborhood to the next, but things like city infrastructure, types of businesses, quality of sidewalks and streets, safety of living environments, access to healthy food, and even access to healthcare can vary a great deal within a city. In San Antonio, there is a 20-year gap in life expectancy between South Side and North Side residents. That's not hyperbole, though it may sound as if it must be. And as we're faced with startling statistics like these, not just in San Antonio, but all over the US, we're left with the question, what do we do about it? From the H.E. Butt Foundation, this is the Echoes podcast. On today's episode, we're welcoming Dr. Lyssa Ochoa. She's a board-certified vascular surgeon in San Antonio, and after recognizing the gaps in care by zip code, Dr. Ochoa founded the San Antonio Vascular and Endovascular, or SAVE, Clinic. She works to improve access and compassionate care for diabetics across the city and has partnered with other organizations to develop amputation prevention programs and raise awareness for equitable access to healthcare. We recently featured Lyssa in an Echoes magazine article, and we're thrilled to have her here today. I'm here with my co-host, Marcus Goodyear. Welcome, Lyssa.
Thank you so much for having me, Camille and Marcus. It's such an honor.
Yeah, we're so glad you're here.
Now, I know we have lots to dig into, but perhaps the best place to start is with that alarming statistic we shared that there is a 20-year gap in life expectancy between San Antonio's South Side and North Side residents. Can you tell us more about that?
The fact that lifespan can vary up to 20 years north and south, has a lot to do with everything that you just mentioned in the beginning. But when we want to look at, the things that most people think about is direct access to healthcare. And that means two things. One of them is access to health insurance. So the reality is that Texas has the most uninsured patients. We rank last in the
Whoa.
country as far as how many
Wow.
uninsured we have. And there's
I
no doubt that lack of access to health insurance is part of it. But even so, lack of access to healthcare itself is very different north and south. And what happens is we don't have enough primary care doctors, we don't have enough pediatricians, we don't have enough specialists. And what's happening is that our patients on the south side, I say our patients, our community or people on the south side begin to suffer chronic medical conditions very, very early in life. So I am seeing patients that are in their early 30s and 40s with uncontrolled diabetes, high blood
Whoa.
pressure, high cholesterol. They're suffering heart attacks, strokes. They're going into kidney failure, needing dialysis. They're going into heart failure. And the conditions and complications that we're used to seeing in an elderly population of more maybe 70s and 80s,
Yeah.
we are seeing in our 30 and 40-year-olds. And so it is the combination of all of that, of not having insurance, not having access to healthcare, health literacy.
Wow.
Texas is last in health insurance. How? How did we get there?
Yeah.
Well, I think one of the issues is Texas has not expanded Medicaid. And when that happened during the ACA, the federal government was giving states extra funding to expand Medicaid. And so the reality is we have a lot of patients, a lot of communities that can't afford private health insurance, that maybe are not employed, and they fall in between kind of a window of what the ACA or the Affordable Care Act has that you can get online at healthcare.gov, and then what qualifies them for Medicaid. And it's that gap that makes it hard. But the reality is there's another gap. Not only is there a gap in do they qualify for some kind of health insurance, But what I have seen on the South Side, when I see patients, I've had some that have come without insurance. And what I've learned is once I pair them with just the right navigator, someone who will sit with them, see what their finances are, see what their medical needs are, and really
Mm.
find how to pair them and guide them step by step to get a plan that's best for them. In my personal experience, I'd say over 90% of those patients are still insurable.
So advocacy, you're seeing advocacy is key here as well.
Advocacy and helping people get insurance.
Now, I mentioned that you work a lot specifically with diabetics, and I'm wondering if you can tell us a little bit more about diabetes because I know there is often confusion between type 1 diabetes, type 2 diabetes. Some people, are like, are you causing your problems or, that kind of thing or didn't you get yourself here kind of deal. Can you just unpack that for us and kind of shed some light?
Sure. I'm actually going to unpack it a little more because I'm a vascular surgeon. So inherently, my patients, I don't take care of diabetes myself, the condition itself. I take care of its complications. And so the
Mm.
Mm.
reason that I see a lot of diabetics is that diabetes affects all the blood vessels in the body. And so the difference between type 1 diabetes, which means that you actually don't produce any insulin at all. They say this is the one that you were like when you get when you're younger, I think is what most people think of it as. But usually it's some kind of autoimmune thing that shuts down your pancreas and you don't produce any insulin. And so you'll hear doctors call these as a brittle diabetic, meaning
Mm.
it is like the on and off switch with insulin. Like if you eat something, you definitely need insulin. You turn it off, you can't. Where type 2 diabetes is actually a result of insulin resistance. Initially, you produce insulin, but your cells don't respond to that insulin. And what that means is so insulin is a signal that tells your cells, hey, bring that sugar into the cell to use it, whether it's a muscle cell or a fat cell, and it's unresponsive to that signal. And so that's why there's so many different more medications to either stimulate producing more insulin or to make it more receptive to that signal. And so type 2 diabetes is what we call an acquired condition, meaning over time. The reason that these patients, both type 1 and type 2, end up seeing me is diabetes affects every blood vessel in the body. And I try to explain to patients that it affects the small, tiny micro vessels in the body. And diabetes, it usually affects the larger blood vessels in the feet and works its way up the leg. In the larger blood vessels in your heart, that can cause a heart attack. The blood vessels to your kidneys, it can begin to damage your kidneys and how they end
Whoa.
up on dialysis. The blood vessels to the brain, that can cause a stroke. And then, like I mentioned, the small vessels in the eyes and the retina. And, diabetes is a leading cause of blindness and vision loss in San
Wow.
Antonio.
Whoa.
And so that is
In
because
San
of
Antonio?
yes. And that's the
Wow.
most leading cause of the reason people are on dialysis in San Antonio. Now, for example, in other areas, a hypertension or high blood pressure may be a bigger cause for people to end up on dialysis. But in San Antonio, it's diabetes. We have on the south side very high rates of diabetes. Overall in San Antonio, Oliver County, I think the average is now about 14-15%, which is still high. But if you focus in those zip codes and those populations, we have diabetes rates up to 20-30%.
Wow.
Wow. That is a lot of information, but very, very illuminating for sure. And so I know that you're speaking a little bit to this, but much of your work that you've mentioned previously, you've spoken about amputations. And what are the disparities you're seeing specifically with amputations, and what leads to that disparity?
Well, the disparity in amputations is the same that we've been talking about. And so the end stage complication of having bad circulation to a foot that produces a wound that may prevent infection in the bone, the end stage is an amputation. One of the biggest issues that I've surveyed my patients, like, why don't you show up to your appointments or what is your challenge? And the number one thing is actually transportation. And number two is actually finances. So even when they have some resources, it's challenging for them to get to doctor's offices. But everything else that goes along with that, right?
Yeah.
I tell my patients, I want you to go home and I want you to walk. Walk is great exercise. They said, but I live in a place that doesn't have a sidewalk or the sidewalks are broken or, it's kind of dangerous to walk outside. We
Oh,
have,
wow.
and so it's hard for me to expect them to do something basic like walking and exercise to help prevent complications when those are the neighborhoods that they live in.
Oh, the things we take for granted. The things I'm just thinking the things that I take for granted of feeling safe as I take a walk,
Yeah,
right?
yeah. I mean, even just the parks down at the end of my street and things like that. Do you think this is something most people realize? Is this something most doctors realize, and that like the word isn't out?
I can tell you that unless you've come to the south side of San Antonio and really kind of invested yourself in this community, they don't know. And I tell my
Wow.
colleagues from the north side, did you know that we have diabetic amputation rates that in some zip codes are maybe, you know, 15 to 20 times higher than that in other zip codes in the north side? And they have no idea, which is why I say it's so important that we need to spread the message and continue talking about it, not just around Diabetes Awareness Month or Heart Healthy Month. Needs to be a topic all the time.
Yeah.
I mean, how do they feel when you share this with them?
Most of them sound surprised. Some will say, "What? I've lived in San Antonio my whole life. I was born here, I was raised here, I went to college here, I work here. I had no idea that that was happening on the South Side." To this day, right now, as far as access to acute care in San Antonio, meaning a hospital you can go to for a heart attack or pneumonia or a diabetic foot ulcer, on the South Side of San Antonio, we have only one hospital with only 100 hospital beds for over 700,000 population. On the north side, we have
Whew.
over 4,000 beds for 1.5 million. And when tell my colleagues who work, solely on the north side, they're like, "What? Really? I'm so surprised that there's not more access down there." And so when you really put a number to that statistic, the statistic we follow is how many beds do you have per 1,000 population? Currently on the south side, we have 0.14 beds. On the north
Wow.
side, we have 2.94 beds. And so that is just such a very large disparity. And so in May of 2023, there was a Southside hospital called Texas Vista, previously called
Right.
Southwest General, that had shut down. It had maybe 250 to 300 beds, and they had some mental health beds as well. 3 to 4 months after that hospital shut down, in my practice alone, I saw a threefold increase in diabetic amputations in people younger than 50. So,
Whoa.
this to and I
These are
recognized it
startling.
right away.
Yeah.
It was, and I was like, this one thing where that hospital shut down and created a vacuum of acute care, it
Wow.
made it harder for people to go to an emergency room, to get to a hospital. And, in my world, we say time is tissue. And if you have a
Hmm.
diabetic foot ulcer and it's infected, the amount to time to get to care is critical.
I'm just having a lot of personal realizations, right? Just thinking about what I mentioned in the opening, that it's not perhaps just that my parents moved across town and improved my schooling, but that there's a possibility that they increased my life expectancy by 20 years. Just thinking about that is really rattling me. But not everybody can do that, right? Like not everybody can just move. What do you see people doing to try to improve the conditions?
I've met a lot of people and a lot of organizations and who are doing a lot of different things in San Antonio. I'll give you one example that actually had been published in the New England Journal of Medicine. Dr. Roberto Trevino, he was a critical care doctor long time ago and realized that diabetes was affecting his community where he was from on the west and south side of San Antonio. And he created a program to educate middle school children about nutrition, exercise, and understanding, how sugar is processed in the body. He helped train teachers, gym coaches, people, cafeteria workers, parents. And he actually showed that with this $10 to $15 program, we could prevent childhood diabetes and prevent childhood obesity and diabetes in the long run.
Whoa.
He's actually written a book about it, and he's published in the New England Journal of Medicine that this works. Like those low cost,
Mm.
widespread interventions work.
I'm realizing that we talked a bit about amputations, and I don't know that we talked about the gravity of that. Can you talk
Right.
about some of the realities for amputees and what that even looks like and some of the ripple effects?
Well, having an amputation, as you can imagine, is life changing, and I have to tell you, this is why I'm here. One thing I've learned about in these communities is that they are resilient.
Yeah.
Okay. I'm
Hmm.
going to start with they're resilient and our goal is to keep them walking. Our goal is to keep them walking with a
Yeah.
prosthetic. But the reality is, once they have an amputation, they're probably in the hospital for 2 to 3 days. Ideally, if they have the insurance plan that allows them to, they get to go to an inpatient rehab where for 2 to 4 weeks, they are taught how to transfer, how to keep their other, legs strong, how to use their arms, and really trying to, because the reality is you need 1.5 to 2 times more strength to walk with a prosthetic than to walk with 2 legs. So
Whoa.
you actually have to build strength and balance that wasn't there before. Depending on how fast they heal, the staples come out in 4 to 6 weeks. If everything goes smoothly, in 4 to 6 weeks, they get referred to the prosthetic company to begin to fit them for a prosthetic, and that's a process in itself because as that stump heals, it first swells, but then it begins to come down, and so there's a lot of changes in the volume of their stump. I do have some patients who the moment they get their prosthetic, they're up and walking.
Yeah.
I have some that it takes months to find their balance, to get that strength, to get that comfort, to get the right fit, and that's
Yeah.
just the patient themselves. What we don't see in between there are the support that they need to get them places, to keep
Yeah.
them in the right mental state, to transport them to all their doctor's visits, to keep them doing their physical therapy exercises at home. And that's where family, friends, and the people around that patient really are affected as well.
Yeah, it's almost as if the same systems that put them in this situation are going to make it harder to recover.
It definitely can be. And so some of my patients have lost a job once they've gotten an
Mm.
amputation. I still have some that say, "My goal is to go back to my job." But
Hmm.
that still, takes a process. It's, challenging because we see the amputees in the hospital and most people don't see them afterwards, and I am fortunate that I see my
Mm.
patients for their entire lives. I see
Wow.
them till they pass away. I tell people I'm like the primary care of vascular, vascular of all the blood vessels in the body, so I see my patients until they die, and unfortunately, some of them go on to lose a second leg, and the reason
Mm.
for that is, like I mentioned, once we get to the point of just a diabetic foot ulcer, their first diabetic foot ulcer, that's a sign of systemic disease, and the reality is that the 1, 3, and 5-year survival rates after a patient's first diabetic foot ulcer is 90%, 70%, and at 5 years, less than 50%.
Wow. I think for me, just such good information. Even, obviously at the foundation, we're exposed to some of this information from our initiatives, but I'm just learning a lot. So just thank you for all you do. I also wanted to have us tap a little bit into this notion of the differences in zip codes and how we know that there are likely some historical roots there. We have spoken about in the past, and in our article where you're featured in Echoes, we talk about redlining. Can you tell us a little bit about what you found out about the connection between redlining and tell us more about that term, of course, and then what the realities are in the present?
In full transparency, when I first moved to San Antonio, I had no idea what redlining is. My major
Me
was
either.
chemistry and minor in biology, and
Ah,
then it was medicine my whole life. But when I first moved to San Antonio, it didn't take long because I did work in hospitals all the way north to Northeast Baptist, Northeast Methodist, all the way downtown to the South Side. And it didn't take me long just to see the disparate care, the difference in demographic, the difference in the quality of care, realizing that I was doing more amputations in certain areas than others. And at some point, I'm like, I'm a private practice surgeon. I would not think that this is what I would be seeing. Why am I seeing geographic differences? And that's when I met Dr. Christine Drennan, who I think we all
yeah.
know. She's of Trinity. She is who taught me about redlining. And so redlining was a practice in the 1930s that during the Great Depression, the federal government wanted to figure out how we help American families rise out of poverty. And they thought, well, if we help families finance the home and the land that they live on, they can build equity. And with that equity, maybe they can buy a car so they can get a better job on the north side, or they can send their kids to college, and really was kind of the basis of being able to rise out of poverty. What happened at the same time, though, is the federal government went into every large city in the country and delineated certain areas as either attractive to London or hazardous to London. And it is no surprise that if you look at a 1930s redlined map of downtown San Antonio, It is the near west, south, and east sides where our black and brown populations were that were redlined. And it wasn't not just because of poverty or lack of finances. I mean, if you look at the east side right now of San Antonio, you'll see those old mansions and realize that there was some real wealth on the
Yeah.
east side, and they were still red line neighborhoods. And so what was segregationist and racist in the 1930s and was intentional has created systemic policies and lack of investment in these neighborhoods that result in what we see today. And so I have a presentation where I show a map of a redlined neighborhood, San Antonio. I show a diabetic amputation map of every zip code. It looks exactly the same. I show a map of the hardship index, which aggregates social issues like educational attainment, poverty, crowding in a household, and compares one zip code to another, how hard it is to live in that zip code. It looks like the same map. And so that's why I believe that we have to use the same energy and intentionality to be able to, let's say, to fight to reverse that, to reverse those
Yeah.
practices. We have to focus our strategy, and actually, I use that map of diabetic amputations to say, "Where am I gonna put my clinics?" Because 'Cause I'm gonna
Mm.
put my clinics in the zip codes with the highest diabetic amputation rates, so hopefully I can have a bigger impact.
So, in a sense, you're investing in these communities that did not receive the historic investments that some other communities might have received, that were deemed good investments to lenders.
Yeah.
That's right, and so I it's interesting you said, yes, I have chosen to invest in this community. I've been told by several, like, "Oh, you're in the wrong area, you're not in a place that's gonna make money." My practice and my husband, who is the administrator of my practice, we've built the only Medicare accredited surgery center in all of South San Antonio, and that's because we wanted to create that access for specialty care like ambulatory care, and so our dream is to create this, surgery center that attracts all those specialists so that we can provide the care here closer to patients in their neighborhoods.
You're talking a little bit about it already, but I'd love to hear more just about the Save Clinic. What led you there? You've spoken about that a bit, and the impact that you've seen.
The reason I started the SAFE Clinic is really because for the first 6 years of practice here in San Antonio, I was witnessing that disparate care, preventative human suffering on a daily basis.
Yeah.
Hmm.
When I sit there and I'm telling families that I need to do an amputation on someone in their 30s and 40s that are younger than me, it just really tears at your soul.
Yeah.
And I know it needs to be done, but I really couldn't stop and witness on a daily basis preventative chronic illnesses and complications being suffered by communities when I knew it was wrong. I can't just keep doing the vascular surgery.
Yeah.
I really had to figure out how do I use my experience as a vascular surgeon and what I'm witnessing for advocacy and to change things upfront. And upfront is way before they come see me. Upfront is when they're in elementary school and middle school, when their neighborhoods are being built. Do they have healthy grocery store with healthy fruits and vegetables? Do they have good tree coverage for not only for clean air, but we actually know that the more amount of green environment you have, the less risk of cardiovascular disease you have.
Wow.
Wow, what's the connection?
It's one, the clean air, and it's just about being around nature also that has a
Huh.
calming effect. So there's no doubt that everything
Whoa.
leads to any kind of inflammation and stress can lead to more cardiovascular disease. And so it's when I realized that that happened, I needed to use the SAVE Clinic one as a model to figure out how do we address delivering quality care to underserved areas and how do I show all my medical community that it's possible, that it's financially viable, that we are fulfilling our mission to take care of our patients and why we went into medicine, and that we are making meaningful change in these communities. And I was always told and trained by the surgeons who trained me that as a surgeon, you're the leader in an operating room, but you're the leader in a community. And it is your responsibility to give back and lead where you see change that needs to happen. And so I thought at first that by creating SAVE and putting clinics out in the areas that needed that I would make a change. And I'm going to be very honest, I haven't seen this robust change in diabetic amputations. And it's when I reflected and realized it's because the 80% of healthcare outcomes are affected by the social determinants of health and only 20% direct care. So I
Hmm.
I can do all the surgery I want to do, and I'm not gonna have a big impact. What we really need to address is how we got here in the first place. And we need to figure out how we help our communities be healthy communities without them having to move to the north side.
Yeah.
So, how do we create communities where there's safe places to walk and exercise, that there is clean air, that there's tree coverage, that they can go to their public school and get a quality of education and know they have the opportunities to programming and pathways just like they do on the north side? That we create transportation that's equitable.
Well, hearing about the importance of community, hearing about all the different things that go into health, from education to the environment to understanding of food to the infrastructure itself of healthcare, reminds me of a clip from the Laity Lodge archives. This is from a fairly recent retreat from 2020. It was actually the last retreat we had before the pandemic shut things down, and it was called Neighboring Together. And this is a clip in which Michelle Legalia Holland is talking about the idea of beloved community, which is something she will explain. So we're gonna play this clip, and we just love to get your take on it. Tell us what you think.
I learned about beloved community through the work of Martin Luther King. Some of us are very familiar with the quote that my liberation is bound in yours. When I'm not free, you're not free. When you're not free, I'm not free. And he recognized that there was what he described as an inescapable network of mutuality that binds all of us. And when we do work in isolation, we fail to recognize that we have ripple effects across all of those communities, and therefore our work should be about transformation so that we can achieve the beloved community.
When you hear that, what resonates? How does that feel like it applies to the things we've been saying?
Well, I'm gonna start with Michelle Lugalia Holland is a good friend of mine.
Oh,
Oh, how
wow.
fun!
We've have interacted much, and she speaks to my soul, all right?
Oh, I
If
love
only
that.
I was as eloquent as she was. But I can tell you the idea that we are all connected and that we all affect each other. I think that's an important message for all of San Antonio. I have heard some people say ridiculous things like, "Well, I don't wanna pay for someone else's health insurance. It's not me. It has nothing to do with me." And so the reality is that the health of all of San Antonio should matter to all of us. And the reality is
Yeah,
that the foundation of San Antonio are those blue collar workers who may be construction workers, who may help clean our hospital beds, who are the cafeteria workers that help feed our children. They're the ones who showed up during COVID. They had to. They're
Yeah.
the ones who bear a larger burden and a bigger sacrifice to take care of their families, and they affect us all. And so, if we don't have a healthy South San Antonio, East Side San Antonio, West Side San Antonio, we're not gonna have a healthy economic development for all of San Antonio. My message for people are that you should care that our students on the South Side get a good education. You should
Yeah.
care that we have access to healthcare because ultimately, in one way or another, it does affect us.
Yeah.
And so I'll go on with that example. I'm not going to pay for someone's healthcare, is some comment I heard from somebody. Well, someone who doesn't have healthcare, you still pay. That
Yeah.
that patient ends up at the end stages of illness, critically ill in a hospital, in the ICU where there's the most money, and those hospitals do get reimbursed for that care, and that's our taxpayer money. And now the $15 we could have spent in middle school to prevent this from happening, we are spending tens of thousands for a critically ill patient, that could have been prevented. And so my message is we all have to care about each other. We all have to understand that we are all connected. And I do like
Yeah.
just that simple sentence, when I'm not free, you're not free.
Yeah.
And when you're not free, I'm not free.
Oh my gosh, all it's just so important. I am just wondering some takeaways for our listeners. At the foundation, we highlight the importance of being a good neighbor. How can we be better neighbors when it comes to the topic of health access disparities?
That's a good question. You know, I do a lot of community talks and educate, seniors and patients. And one thing I tell them is, when you're here listening to this information about peripheral arterial disease, this is not just for you because how many of your friends and families or your neighbors do you know have diabetes? Do you know
Yeah.
have peripheral arterial disease? I want you to share this message with them
Mm.
and teach them. I alone am not gonna get that message out. And so I think it's both, not only empowering those who are able, but empowering our communities themselves because they can help their own communities by educating their friends, their families with the things that they learn, and connecting them to resources that maybe someone has connected them to. I always tell people that, look around you and lend a hand, when you can. Sometimes most people will not ask for help, so offer it up front.
Yeah.
And if you offer it up front, I'll tell you, most people don't take it, but the ones who need it will. And so one example of that is every patient that I see gets my cell phone number. And
Whoa.
so
Wow.
I get very few phone calls. Uh,
Mm.
and I tell them, this is not so you can crank call me or we can chat in the middle of the night.
Yeah. Yeah.
This is for an emergency. And when you can't get a hold of them, I will always be here for you and I will
Mm.
answer that phone. I don't get many phone calls because most of my patients say, "We don't wanna bother you. We respect you and your time, and we just
Yeah.
don't wanna bother you." But there is something in, that security of knowing that if they need help, someone will answer the phone.
Such
And
a good
so
message. So a big takeaway for us is look for need, ask folks what they need, and then be there if you can meet the need.
well said.
Yeah. Yeah.
Camille, I mean, that's what Mary Holdsworth Butt did, right? She would just
Exactly.
listen to what the community needed, and
That's
then
right.
no matter what it was, she would
Our
try to
founder.
help.
Yeah.
Yeah.
Yeah. Yeah. Lisa, thank you so much for being here. Thank you for the beautiful work that you do and for sharing with our communities about the needs that we can really come together and try to meet. Thank you. Appreciate you.
Well, thank you, Marcus and Camille. It's been a great conversation, and I think we need to have more of them more
Yes.
often.
Yes,
Yes, for sure.
absolutely. Thanks so much.
Thank you.
The Echoes podcast is written and produced by Marcus Goodyear, Rob Stinnett, and me, Camille Hall-Ortega. It's edited by Rob Stinnett and Kim Stone. Our executive producers are Patton Dodd and David Rogers. Special thanks to our guest today, Dr. Lyssa Ochoa. We recently featured Lyssa in Echoes Magazine, and you can read the article online at echoesmagazine.org. While you're there, consider subscribing. You'll receive a beautiful print magazine each quarter, and it's free. You can find a link in our show notes. The Echoes podcast and Echoes Magazine are both productions brought to you by the H.E. Butt Foundation. You can learn more about our vision and mission at hebftn.org.